Welcome to Early Intervention Matters, the podcast that helps parents, teachers, and health professionals understand the diagnosis, treatment, care, and support of children with autism, ADHD, Tourette's, and other neurodevelopmental challenges. Your host, Dr. Inyang Takon, is a consultant neurodevelopment pediatrician, and she will provide insight through interviews, answering questions, and breaking down complicated topics. By sharing stories from parents and professionals in the field, we hope to make sense of what can be an overwhelming topic. Early intervention is crucial with children with developmental difficulties. Yes, early intervention matters. And now, here's your host, Dr. Inyang Takon.
Hello, everyone. Good evening. You're welcome to this episode of Early Intervention Matters. We're in for a very interesting episode tonight because we're so pleased to have Keith Donato, who has been here before. We were very privileged to have Keith in July when he talked about sensory difficulties, and that was a very popular session. So if you haven't listened to it, please do listen. So Keith Donato is a pediatric occupational therapist with nearly a decade of experience in sensory integration and other child development and neurodiversity. Keith practices in Abu Dhabi, in the United Arab Emirates. He supports children with autism, ADHD, cerebral palsy, and motor planning challenges using evidence-based and culturally responsive approaches. He also has university-level teaching experience in occupational therapy with a focus on bridging theory and practice. I was so privileged to meet Keith this year when I went for a conference in Abu Dhabi, and straight away I found Keith very knowledgeable, very engaging, being able to break through barriers and explain things in very simple ways. I also found he had a lot of empathy and a lot of drive and desire to make services accessible to every child, no matter where they are. So we do hope that people will learn and be able to get something from our conversations today. So you're welcome, Keith. Welcome back to the platform.
Hello, everyone.
And
It's good to be back. I'm so honored to be back. Um, when Dr. Takan asked me to have a second podcast, I said yes immediately because it's an honor to be part of a mission to spread knowledge and awareness to everybody, especially for topics that are overlooked, such as today's topic, which is about sleep difficulties in typical and neurodivergent children.
thank you so much, Keith. You're very welcome. And I'm Dr. Inyang Takon, who's the host of this podcast and a neurodevelopmental pediatrician as well. So we're talking sleep today. Keith will be sharing information, and Keith also has some questions for me as a neurodevelopmental pediatrician, because the interesting thing is our work is such that we see children with neurodiverse conditions, and sometimes they might go to Keith first, and sometimes they come to me first, and then I will direct them to occupational therapists, and sometimes they might go to Keith first, and then the children might need a neurodevelopmental pediatrician for some aspects of their care, which is the reason why it's really great working this way. And so we're going to be reflecting typically what happens in practice, but we are going to be sharing information. So you'll be hearing from both of us, which is great. So if we kickstart with you, Keith, why is sleep important, and what do we mean by normal sleep pattern
Okay,
for
let's start with the
children?
basics. So, a normal sleep pattern depends on age and rhythm, but it's not just about the total hours, it's more importantly about the quality of the sleep. But when you based it on age, a toddler should get sleep about 11 to 14 hours. For preschoolers, about 10 to 13 hours. School age, about 9 to 12 hours. And teenagers, 8 to 10. But when we're talking about patterns, a healthy pattern is a predictable sleep and wake times, and they're able to settle for sleep within 20 to 30 minutes, and they can sleep throughout the night without minimal or without waking at all. And when they wake up, they feel refreshed. So that's a normal sleeping and healthy pattern.
Thank you. That's so important. And I think this is really key because it's not just the hours, it's about the fact that the child has been able to sleep, have a good quality of sleep, and wake up feeling refreshed. This is supposed to be the normal expected pattern for most children. But today we're going to talk about things that can go wrong in that process and what we can do. So, how can the parents promote normal sleep patterns in children and young people?
Well, first of all, every child is unique and every household is unique, but they need to understand first how important it is for their child to have a normal pattern of sleep because sleep is foundational for growth, brain development, and it can even balance the appetite and hormone. But for an OT perspective, we treat sleep as a 24-hour task. I think that's revolutionary. So, sleep is not only for the bedtime, it starts for the moment they wake up. Because every child's task, activities, everything they do, and every leftover is carried through the bedtime. So, as OTs, we do not only treat the bedtime, but we also treat the entire 24-hour rhythm of the child's body, environment, and sensory experiences and routines. So, let's say when the day is chaotic, loud, emotionally overwhelming, naturally, bedtime will become difficult because the body has not completed the regulation cycle. But otherwise, if the day is regulated, then it will be a very easy night for both the kid and the parents.
Absolutely. I think you've just said something that is so, so important. And I think this is one aspect where people sometimes don't realize the importance that it's actually the total sum of your day. So sometimes parents would be, I just want him to sleep, to just have, this hours of sleep. But people might forget what has gone on through the day. If the day is not settled, if the child's day has been chaotic, then it's going to be difficult to expect the evening to be settled and for the child to sleep. So it would be great if our listeners could take that on board, that what matters throughout the day, it's important. So what kind of sleep difficulties do we see in children and young people?
Well, in my practice, uh, basically, parents come to me, their kids having diagnosis with ASD, ADHD, multiple disabilities. They don't mention sleep at all. Actually, they only mention hyperactivity, inattention, focusing problems, behavioral problems. And even some of my colleagues even don't ask about sleep. But I voluntarily, or I have this instinct. My first question is, how is your child's sleeping behavior? Because when they get shocked, mostly they get stunned by that question because normally it's not brought up in the clinics at all. They come to the clinic because they have problems at home, but they don't see sleep as the problem or a root cause of the problem. And some of the types of sleep difficulties that I have gathered from their answers are insomnia, night wakings, early morning wakings, circadian rhythm delays, sleepwalking or night terrors, some medical difficulties, and behavioral sleep problems, anxiety driven or sensory driven. But from a pediatric neurodevelopmental perspective, Dr. Inyan, what are the sleep difficulties that are related to medical reasons or not related to sensory or behavioral?
So, thank you, Keith. It's a very important question because when children have sleep difficulties, we have to go through a series of questions to just help us determine whether this is a behavioral or sensory problem. And then we go through the medical things. One of the common medical problems that we can see are children who snore at night, and this might be because of enlarged tonsils or enlarged adenoids, and you'd find them falling asleep, then breathing heavily, and then suddenly stopping breathing for a very short period of time. Parents would usually say to you, "Oh, he snores at night," and then I don't hear him after some deep snoring. Now, when we get that kind of history, we think about conditions like obstructive sleep apnea. And that is very important because that is something that requires medical attention. It requires that child being referred for their assessment, and possible some of those children might need surgery with their tonsils and adenoids being removed. And it's interesting how their sleep improves after this procedure, because what happens, that child's sleep is fragmented. So every time they fall into a deep sleep, they're snoring, they suddenly wake up to catch their breath because of their enlarged tonsils and adenoids. So that's one of the medical problems. There are other things like if the child has what we call restless leg syndrome, and this is a condition where the child might be very, very restless at night, constantly moving, cannot sleep, is very active. Some of these children may have some deficiencies like iron deficiency. And so if parents are observing a pattern with the child being very restless, then it's important that the child is referred and has investigations done. Some children may have seizures. We know some children may have a type of seizure, that some types of seizures happen at night. It might be either when they're falling asleep or, going into sleep, or some of them might wake up in the middle of the night with seizure. So it's always important to, get a history of what is actually happening at night when the child is having this movement.
Oh, that's very interesting. You said earlier that when they have obstructive apnea and they have fragmented sleep, does that affect their quality of sleep? And do they wake up refreshed or not?
No, they usually wake up quite tired. It affects the quality of sleep because many times, if you think about what's happening, the airway, which you should have a nice flow of your oxygen through your airway at night because your brain needs oxygen. So if you find the child waking up several times a night, because the waking up is to, almost like resetting to have the child breathe and get the airway open. So if a child is having to do that several times a night, then that child is going to have a very disturbed sleep. And sometimes what you get alongside that snoring and waking up at frequently, you get daytime sleepiness and tiredness. So the child then may fall asleep in the classroom during the daytime, and be quite tired. So you've talked about children having to be refreshed in the morning if they've got good quality sleep, but the child with obstructive sleep apnea does not feel refreshed at all. The other thing I forgot to mention, that children who are overweight might be prone to developing obstructive sleep symptoms. So again, that's kind of a health medical issue, that if they're overweight, then you can have sleep problems and struggle to stay awake during the day. So yeah.
Thank you. That's very insightful. That just says how important it is to distinguish a medical versus
Yeah.
a behavioral sleep difficulty, and
Hmm.
how to get medical help as soon as possible if you have identified it.
Yes, it's so important, and it forms. When children come in with sleep problems, I think the danger these days sometimes is people think, "Oh, my child has a sleep problem. I need a sleep medicine." And if that child's sleep problems haven't been looked into properly, people might just be giving sleep medicines for something that doesn't need sleep medicines, and it sometimes can be more dangerous for the child if that happens. So I think it's good to make sure that we get a proper history from the child.
Exactly.
So, um, and talking about routines, how can parents promote healthy sleep patterns in children and young people?
I talked about sleep being a 24-hour task, right?
And
And I talked also that it starts from the morning. And what I notice in the modern day, our routines, especially in a typical household, is not really child friendly. It's more of uh, the the parents' routines incorporated into the children. They wake their children early, get ready for breakfast, for shower, for school, and they skip one of the most important key elements of the circadian clock, which is natural outdoor sunlight. Because it no, we don't have time for that because school is starts in this hour, or the bus picks up picks the child up in this hour. So it needs to be, the schedule needs to be tight. But I think we need to have a reform that the morning routine should be child friendly or child led. That the routine should start from the morning in the first 15 to 20 minutes of their waking time. Open the curtains, let the natural sunlight hit their eyes, suppress the melatonin, which is the sleep hormone, and activate the dopamine, activate the brain naturally. Let them move with their breakfast, pair it with the protein in the breakfast, and then go on through the day. And in the nighttime, close the loops. What I'm talking about are the sensory loops, emotional loops, cognitive loops, relational loops, and routine loops. So, if these loops stay open, the child will stay in a vigilant state, and it may be difficult for the child to settle for sleep because they don't automatically reset their nervous system.
Mm,
They're just like us, even us. We accumulate stress throughout the day. Adults accumulate sensory input, emotions, unfinished transitions, and even relational tension. So, typical children and neurodivergent children, if they're at school, they accumulate stress as well. So,
mm,
if those loops stay open, then who's gonna close them,
mm.
right? If the parents just send them to bed, try to sleep, get to sleep now, it's bedtime, but the child is not yet ready to sleep. So, a good bedtime routine is not just about getting ready for bed, but it's about closing all the loops. So, I mentioned sensory loop, which I'm going to discuss further later on, and the emotional loop, which is about how you present yourself, how the parents present yourself to the children, how the emotions are being received and validated. The cognitive loop, do they have residual uh, cognitive load from their day? Relational loop, and this is very important, the relationship between the parents and the child, because anxiety is contagious. If the parent is anxious, it can be transmitted to the child through the tone, through the voice, and through the body language, especially if the child is already having sleep difficulties and it happens frequently. So the parent, once again, at the nighttime, will have this anxious feeling. It's bedtime again. It's going to be another battlefield. So the parent will develop anticipatory anxiety, and it's not good. The parent has to be the anchor. The parent has to say that the child is safe. I am here, and you don't need to stay alert. All you need to do is to just be safe and sleep. And the last is the routine loop. Repeating the same sequence every night provides certainties, provides familiarity, and it lowers the anxiety and reduces the bedtime resistance. Right. So when these loops are closed, it will tell the child the day is finished, the world is safe, you can rest.
That's an amazing explanation, Keith. It's just great how you've been able to talk about these different dimensions, and I think this is so important for families to hear that one, there are all these things that are open at the beginning of the day, and you said something. I bet if I ask a number of families, how many people actually at the beginning of the day start that day by opening up their curtains and allowing the child, some time to take the day in. I bet the numbers will be very small. I think the typical day for most families starts with parents being stressed, they're probably rushing to go to work or going somewhere, or having other children to get ready for school, and then shouting for the child to then start getting ready for school. So you can already imagine how the day has started for the child. And then the
Yes.
child gets to school, carries over that anxiety, multiplies it by having anxiety about the day and what's going to happen and all that. Gets stressed in school, comes home, big meltdown, finds it difficult to settle. So you can imagine how the sleep difficulty the child would have would would be, because they've just struggled to turn off all these loops at the end of the day, and you've had a stressed parent as well. I think this is a great explanation, and one that is quite useful for families to understand, that taking a step back and just making sure all these things are covered is so important. So, you've also talked about something which you said things need to be consistent. Do you find in your practice that this is a problem with consistency?
Yes, parent history is not really reliable sometimes.
Mm,
Sometimes they're embarrassed to tell the truth, right?
mm,
So if we suggest something, the carryover is not really that good. So we are having difficulty with consistency, but not all the time. Some parents are very proactive,
mm,
and they really are consistent with the strategies. But the takeaway here is, you don't have to apply a lot of strategies, to be
mm,
consistent. You
mm,
can just choose one strategy and then build it up as you progress.
mm.
I have a question for you, Dr. Yang.
Yeah.
What patterns do you commonly see in children who struggle with sleep at all?
Yeah, so I get lots of children with sleep being a problem, especially in the neurodiverse population. And the commonest thing which parents report is the child finding it very difficult to fall asleep. So there's late bedtimes, sometimes stretching past midnight. Sometimes parents have even gone to sleep and the child is still awake. Sometimes a few of the children will stay in their beds and not necessarily sleep, they'll sleep later, but they would find things to entertain them within their bed space. And this is one of the things we tend to talk about, is about the room environment, the bed environment. Some would, you know, fall asleep but then wake up and have this fragmented sleep pattern. But the commonest one, a pattern I see, is the child not falling asleep. And so
Mm,
many times parents want something to just make them fall asleep because the child has stayed awake past midnight, past their usual bedtime. And despite us talking about sleep hygiene, I do find that some families find it difficult to maintain consistency in ensuring those disciplines are there.
If there's an inconsistency in sleep, then the poor sleep will have bad consequences, correct?
Yes,
So, for the child and for the family. For the child, it
absolutely.
may be behavioral difficulties, impaired learning and memory, and sensory problems. Is it true that there's also increased cravings for sugary food due to hormonal imbalance? As I've read in the research, that when children don't get enough sleep, their hunger hormone balance changes, and there's a stronger drive and desire for quick energy foods to fuel them up because they're so tired.
We've heard this being reported, but we don't have the strong evidence for that. But we can talk about anecdotal or parental experience. So you find some of these children with poor sleep patterns having a drive to continue to do things, to seek things, and that might include food, or they're just seeking things constantly to keep them going. And one of those
Mhm.
things sometimes children seek is to be on screens for a very long time, and parents do find difficulties in transitioning them away from to getting the screens off them,
That's true.
and that becomes a bigger problem. And some parents will say, well, without the screens they can't sleep, but you're trying to encourage a healthy sleep pattern. So it is almost like a vicious cycle, that we have difficulties with the children, you know craving all kinds of things. I would say, in clinical practice, I don't see a lot of the craving food. They have had some reported where the child would go and seek food. So parents would have thought the child is sleeping, and then the child would have gone to the kitchen seeking food. So I've had some reports of that sometimes, but I've seen more craving for just something to stimulate them. Phones, tablets, TVs. Yeah.
So you're saying that a tired body that's seeking for stimulation add that with constant tension and a lot of accumulated stress, then it would lead to somebody that looks like hyperactive, correct?
Yes, yes. Because sleep is a regulatory function for your body. Sleep is needed for a lot of your body metabolism, your growth, a lot of things, your brain function the next day. So when that doesn't happen the way it should be, then you're going to have a dysregulated child the following day. And therefore, things like your learning and other things will be affected. The child can come across as being, yes, hyperactive if the child just has a lot of sleep problems.
All right.
And that's why we also know that there's a high incidence of sleep problems in neurodiverse children with, say, ADHD and autism spectrum disorder. But at the same time, poor sleep can worsen the presentation of those conditions. So if the child sleeps poorly, then they're likely to present with more severe symptoms.
That is true. In fact, I have read a recent 2025 ASD sleep medicine study that demonstrated 98% of the cases showed significant sleep problems, including insomnia, night waking, and early awakenings.
Yeah.
82% of them have sensory sensitivity, and 84% showed sensory avoidance. But um, the the final verdict is that the sensory processing difficulties alone did not cause the sleeping problems, but the sensory difficulties made the kids emotionally destabilized,
Yes.
and emotional dysregulation caused the sleep problems.
Yeah, so that's very interesting, and I'm not surprised, but because, like I said, sleep helps your body regulate your mood. So if you think about your child, having good sleep is important for their mood. If the child is not having enough sleep, they'll be grumpy, short fused, impulsive, anxious, sometimes aggressive, and doing things they wouldn't normally be doing. It can make them hyperactive because they're completely dysregulated. They haven't had the sleep that's required for their brain to regulate itself. So it translates into movements. So you can have all these difficulties as a result of sleep. And when they get these mood problems, you can just imagine how they would be around other children. So sleep is a very important function. I think we can't stress that enough, that some of the
Mhm.
behavioral patterns that we see during the daytime might be actually related to the poor sleep the child had.
So, for OTs and for neurodevelopmental pediatricians, it only validates our model that we cannot fix sleep alone without treating sensory, emotional, and the environment together.
Yes, I think, and that's the thing, we need to do the two together. So, for example, the children we see with autism or an ADHD, a lot of them have sensory difficulties. And if you go back, Keith, when you were talking about sleep being a 24-hour task, not just thinking about it during the bedtime. If you think about the sort of day that children with ADHD and ASD would have had, sometimes they've gone through lots of very stimulating environments, very difficult times. There have been times when they've been upset and lashed out during the day. So you can imagine when it comes to the evening, it might be very difficult for that child to fall asleep. And I don't know whether this is a similar pattern with what you see in the neurodiverse population that you see.
It is the same, exactly. And fortunately, with this podcast, I'll be able to provide some sensory strategies to spread awareness for our audience today. So I'm going to go through the systems one by one.
Good.
If you're ready.
Yes, I am. I'm sure the
Yeah.
audience is ready to.
So from the previous podcast, I've discussed about six or seven uh, sensory systems, but today I'm going to discuss the eighth one. But we're gonna go through all of them. So one is visual, two auditory, tactile, proprioceptive, olfactory, interoception, and vestibular. So let's start with visual system, our sense of sight. How do we provide visual strategies for typical children and neurodivergent children? The key here is to reduce visual clutter. Yeah.
Yeah.
So for the bedroom, so these are very practical advices, but before I give advices, you should not follow them all at once. Do not apply them all together. Choose one that you prefer and then gradually, weekly basis, upgrade your strategies. But for walls in the bedroom, I would say use neutral colors or pastel. Avoid bold colors, avoid bright patterns, and avoid LEDs because LEDs have blue lights, the same as what you have on phone screens, TV screens, tablets. So these artificial LEDs, they suppress melatonin and then delay the tiredness. So you have to dim the lighting 1 hour before bed. And I even use this myself. I don't have fluorescent lighting. I have amber lamps, orange color, sometimes bright orange and red orange because they simulate the feeling of sundowning or sunset. Remove visual noise. Bedroom is not a playground. Remove the toys. You have to tidy the surfaces. And if you have a TV in the bedroom, it's best to remove it. You have to start small. If the child fears darkness, you can use a table lamp, and then in a weekly basis, you can dim it further. If the child needs a snack before bedtime, it's better to place the snack on a simple dish, not in a colorful dish or a patterned dish, just to simplify the visual environment. Okay, so let's go on to the auditory system or the sense of hearing. If the child doesn't like silence, you can replace silence with steady, low frequency sound, such as white noise, the hum of the fan or the AC, or rhythmic music. Avoid TV or radio or music with lyrics because these are unpredictable and irregular. You don't know the volume increase or you don't know the pacing of the television. So it's better to have white noise, fan hum, and rhythmic music. If your bedroom feels echoey, you can add curtains and rugs. If you're instructing your child during bedtime, it's very important that your tone in verbal instructions are very calm, slow paced, and for children sensitive to chewing when they're eating their snacks or movement sounds, you can try noise canceling headphones. And that's for sense of hearing. Let's proceed to the sense of touch, the tactile system. The tactile hypersensitivity is very tricky to manage, but you can include the child in the selection of fabrics. Select soft, breathable fabrics like cotton or bamboo. And before using them, you have to remove the seams, the tags, or scratchy materials. And a trick is before using them, you can wash them 2 to 3 times so that the material becomes soft enough and it's ready for use. Bedtime, if the sheets are too cool, you can warm the bed sheets and the pillowcases in the dryer for 3 to 5 minutes. You can even drop the stuffed toy in there, and when it's warm enough, you can it's ready for bedtime. You can even iron your pillowcases. I mean like iron press, but do not uh press directly on the bed because it would leave it would be too hot. So the key here is just warm, not hot. So you have to pair the warmth of their skin with a cool temperature in the room. The ideal room temperature should be 20 to 23 degrees Celsius. It helps the body score heat to release more heat. And tactile hypersensitive children respond positively to deep pressure. So you can do a massage with oil or with lotion before bedtime while reading a story. You can even buy a weighted blanket or a compression blanket under supervision. But the ideal guideline is it should be less than 10% of the body's weight. There's a lot of weighted blankets in you can purchase online. And then you have to keep your bedding consistent because if you have to keep changing your fabrics often, then the child's familiarity will reset again. Yeah. And then we move on to the proprioceptive system, which is the sense of the joints and the muscles. I really love suggesting heavy work play 20 to 30 minutes before the bed. I give examples such as wall push ups, wheelbarrows, yoga poses, or carrying cushions. And for restless movers, they can respond positively with a firm mattress or a compression sheet. It's if there's no medical background uh, that inhibits this strategy, you can wrap the child in a blanket burrito for full body pressure input. That means it switches the body's input and tells the muscles and joints that the day is ending. And we proceed to the olfactory system or the sense of smell. I would like to introduce mild, consistent scents such as lavender, vanilla, or chamomile. But if they're hypersensitive, I would love to suggest only neutral scent, no strong smell, or no strong sense of detergents and air fresheners. You have to keep the scent consistent because smell is associated with memory. So take that to your advantage and keep that memory calm and predictable. And the last system that I love to introduce is the interoception or the sense of hunger, thirst, body temperature, heart rate, pain, or anything that the child feels inside his body. For typical children or even uh, neurodiverse children, it's very hard for them to identify or label their own feelings. So, what I like to offer a strategy is to spot the sleepy signals. You have to be the one to prompt the child how to spot physical signs of tiredness. So, these are the verbal prompts you can tell the child. So, like, mommy or daddy, my eyes are feeling heavy. I'm blinking slower. I'm yawning a lot. I'm breathing slower. My body is feeling heavy. My body wants to lie down. I keep rubbing my eyes or face. And then once they have learned those prompts, then the parents can ask, which sleepy signals do you feel right now? Or if they're nonverbal, you can print out cards that have the words thirsty, hungry, sleepy, all done for the day. So, yeah, it's very important to address this because maybe it's not about tactile, maybe it's not about olfactory proprioception. Maybe they are feeling something inside that they cannot explain. That's why it's hard for them to sleep. So that's why interoception strategies should be included in a standard therapy. And one of my favorite, one of my strategy is using or checking your inside voice. So, what I tell the parents is practice asking your children, what does your inside voice tell you right now? So, the question is your inside voice loud or quiet right now? So, if the child says loud, you need to apply more calming strategies. If the child says quiet, then she or he is ready for bed. So I think I've covered most of it. There's a
That's
lot, but I think that's
absolutely
the standard.
wow. This is a masterclass on sleep. This is fantastic.
Thank you.
Breaking it down for families, what they can do. And I would really urge families to listen and take down those strategies because one of the things we talked about was the impact of the environment, and we don't realize how much the stimulation from the environment adds to the child. So there's some children that would have lots of activities after school. Sometimes parents include children in doing a lot of activities. What's your advice with regards to lots of after school clubs and activities and promoting sleep? What would you advise?
Well, it really depends on what's the outcome, you know? I have to ask for the total history and the results of what they're trying for their children. But I have a lot of caseloads with that. I have a case wherein the child doesn't sleep uh uh until midnight. So the father made him do a lot of daily activities throughout the day, enroll him in gymnastics, and then going to the gym, and then bicycle, a lot of activities to make him tired, and then have a consistent bedtime at 7 p.m. After 1 month, it worked.
Okay.
So that's how long it took for the child to be familiar with the new
Yeah.
routine. There's another case where there was a girl diagnosed with ADHD who frequently wakes up at 2 to 3 a.m. So the parents' strategy was they just let the child engage in her preferred quiet activity, which is reading or soft play. And then when she feels tired, she goes back to sleep. There was minimal talking, minimal responses from the parents, and that was actually good because they did all the right things. When you encounter frequent awakenings, you should not provide stimulation. Since the child is not feeling sleepy, you will encourage the child to do some things, or turn on the lights, or give a mobile phone. No, they responded minimally, and they did that for a few weeks
Mm,
until the early awakenings reduced. The last case I think was a child with ASD. He was not sleeping well. He was not sleeping in the night, but he was sleeping in the day,
mm,
like 10 hours a day in the daytime and awake through the night. And he was very tactile, hypersensitive. So we applied strategies weekly. So week one was consistent bedtime. Week two was adjust the bedroom environment. Week three was we added a calming sensory technique. And week four was we introduced a behavioral support. So that was a full month of intervention. That's how long it takes for a child to become familiar and adjusted with
mm.
with the the intervention.
That's fantastic. So when children come to you, when they come to see you for consultation regarding sleep, can you just talk us through a bit of what you tend to do?
Well, first I take a history,
Yeah.
and then once the child is attending regular sessions with me, I have a personal contact with the parent, and the parents will warn me if the child has slept well or not. So if the child has slept well, then I can go on with my pre-planned activities in therapy. But when the parent would warn me that there was a disturbance in sleep, then I will make adjustments with my activities, either provide calming or stimulating activities depending on how the child presents for that day. For example, there was a case just 2 days ago. He was a preteen. He didn't sleep well. He only slept for about 3 to 4 hours, and he was very hyperactive in the session. And usually, in his typical session, he can do a lot of cognitive heavy tasks really excellently. But on that day, I knew because the parent communicated with me that he didn't get enough sleep. I reduced the load. I introduced more sensory tasks and less
Mm,
cognitive load tasks. So that's why communication with parents is important. And that's why for the audience listening to this podcast, if you're a therapist, um, you I think I think we need to have a reform that prior to accepting clients and ask the parents how much sleep they got because it will guide your treatment session. Because if you knew that the child has not slept well, obviously he will perform poorly, and
yeah.
then your expectations will be already laid out, you know. But if you didn't know, if you hadn't known what was the history the night before,
Mm,
and your expectation was high, then you will have a disappointment and there will be tension in the session.
mm.
So I think it's very important to address sleep first and then adjust the session according to the sleep pattern.
Thank you, Kay. That's so useful because I think communication with parents and getting background information, even about the day the child is being seen, is very important. And I just want you to talk because you've mentioned it a couple of times. So I just thought it would be good for the audience to understand what you mean by the circadian rhythm.
The circadian rhythm is the body's internal clock. It resets in the morning when the melatonin is low, or the melatonin is the hormone that makes you sleepy. So it's in the morning, it's very low. That's why you stay alert and awake, and you wake up and you go on through the day. But melatonin will build up gradually, and especially after sunset, it will build up and it will peak around midnight. So that's why you will have those deep sleep patterns. And then again, your body will suppress the melatonin again after dawn. That's why. And that's how your healthy circadian rhythm works. But what disrupts your circadian rhythm or your internal body clock is blue light. LEDs coming from TV screen, mobile phones, tablets. So that's why if you're the typical household that eats dinner at 8 p.m. and then finishes dinner and some playtime at 9 p.m. and then let your kids have their screen time at around 9:30 to 10 p.m., then it will further delay the physical signs of sleep because it will further delay the melatonin.
Absolutely. And just to say, just like Keith has explained very well about circadian rhythm and the melatonin, melatonin also is naturally produced within us, which is very good for helping the sleep, but it also has a role for the mood and memory. So it's such an important hormone, and we need to be doing everything we can to help regulate its natural production. So that we're not reliant on medications for sleep. So, the children you see that you have done interventions for, what proportion of them go on to still need medication? Or the majority of them improve just with the interventions, with the behavioral and occupational therapy interventions?
I think it's quite low. Quite low meaning most of the kids responded well with the OT, but a few of them, I referred them myself to a pediatrician because I noticed that despite my interventions, there was little progress. So there were a few clients that did not respond well with therapy and needed medication. So I spoke with the father or mother and told them to see this pediatrician and decide for yourself what's the best course of action. But some of them saw some pediatricians and took medicines, but most of them trusted the process. They did get prescriptions, but they did not take the medicines. They wanted to address Um, they wanted to l- uh, exclude out other health issues first. Yeah,
You made the point that I was trying to bring out, that behavioral strategies do work for majority of the children, and it should always be the first um, line management for managing sleep problems in children. Because I think with everything that you have outlined, those strategies, it does show there's so much that we can do to improve sleep. And that was the point I was trying to bring up, that medication should not be seen as a first line for a child.
I agree. Exactly.
Good. Thank you for all that information you've shared with us. You talked about the different loops that need to be looked at to make sure that those loops that have been open during the day are closed at the end of the day, including things like the sensory loop and emotional loop, relationship with parents. And it's just so important, just thinking about the child as a whole and thinking about everything that the child is taking in. We've talked about sleep, what promotes sleep. We've talked about different things that can disrupt sleep. We've talked about some medical causes of sleep. And also, to add to those medical causes, I wanted to say some medications that children are on can affect sleep. So, some children with epilepsy on medications for epilepsy can have their sleep disrupted. And you very kindly gave us a masterclass on strategies for improving sleep, which you went into in such great detail, very easy to understand. So, I would really encourage our audience to look, because those are just golden strategies which you've given to us today. What would be your summary advice for families with children with sleep problems?
Well, I'd like to talk directly to the listener. If you're a parent, I would like to say that you're doing your best. You need to give yourself grace and be patient with the process and focus on yourself first, because your child depends on you. You are the anchor. And as I mentioned before, your anxiety is contagious. So be the firm and confident model that you would like your children to be. So in terms of the strategies that I mentioned, it can be a lot to process all of those things. It's information overload, but it doesn't have to be like that. Pick one, choose one, go with it for 1 week. Write in a simple diary what happened in week 1, what's worked best in week 1, carry over to week number 2, and then add another strategy. Do that with week number 3, and then on number 4, and then review it. Review your month, what worked and what doesn't work. You don't have to be perfectly capable of designing the perfect bedroom or bedtime for your child. You just have to be consistent and patient.
Thank you, Keith. And from a medical perspective, I think those were very important, because when you're looking at your child's sleep pattern, also recognize if there are any of those things that we have talked about which might be worrying. And if there are, would encourage you to seek a consultation with your pediatrician or your GP, things where the child stops breathing in between the obstructive sleep apnea, or if you notice your child having what we call restless leg syndrome, or just having a lot of movements at night, or if your child is having movements or behaviors that you're unsure of, because there's some seizures that can happen in the evenings, and if you're not just clear about the episodes, I would recommend is you video record those episodes and make an appointment to see your health professional, so that you can show them the video and they can see it and decide whether it's significant for further investigations. But there are medical conditions that can poor sleep or wakening a lot at sleep, and if you see any of this, please do seek medical advice. And also, just to say, it can be a very exhausting phase for families. Many families have to still go to work while looking after their children with poor sleep pattern or the sleep difficulties. Sometimes you've tried a lot of strategies, it's not worked, and you're having sleep deficits yourself. It's affecting your own mental health, your mood, your attention at work. Then we recommend that you also seek some support for yourself. There are sleep charities which you can check online for the ones closer to you, depending on where you're looking at this for. In the UK, we have sleep the sleep charities. We also have a national charity called Cerebra, and if you Google Cerebra, they have a very good service. They actually cover some sensory strategies as well for sleep. They also have advice helplines as well. Look for support groups. There are support groups that you can meet other parents who are going through the similar problems, because I think it's good to know that you are not alone with it. Sharing your experiences with other families and maybe learning what they've done in their situation that you could try. Peer support is very important, and we do encourage that. So wherever you are, just check. Luckily, with the online services now, we have information at our fingertips. There's some we can join remotely, but seek some support for yourself and seek help. You might have family members who can support you, allowing you some time to get some time for yourself and look after yourself. Mentioned something. He said, put yourself first, look after yourself because you matter. It's never an easy thing. Sleep is so important. And in terms of how early can you start working on a child's sleep, we say as early as possible. Try and encourage healthy routines, because the earlier you start, the better. I'm not sure whether Keith has something to add to this.
Yeah. Um, since most of my patients get referred to me like around 1.2 years old. So yeah, the earlier the better.
Yeah, yeah. The earlier the better, and the earlier you start putting in a good sleep routine, the better, because then you can build in a consistent pattern. And just to say that for children with neurodiversity, we do see lots of sleep problems. For several reasons, but we can also work on maintaining a good sleep hygiene for them. Sometimes children with ADHD, the ones who are not diagnosed yet, may be coming to us for the first time with sleep problems. So when you take a history, you might understand the whole developmental profile of the child. Sometimes sleep problems might be the reason why the child gets assessed for ADHD or ASD, and just having that diagnosis properly done is quite essential, because sometimes treating the underlying condition like ADHD with the right medicines can help improve the whole day and help that child settle better. So it's been a great discussion, and I hope that the listeners today would have gotten something from the session today and be able to look into the strategies we've talked about. But thank you so much, Keith, for another wonderful session from
You're
you.
welcome. It's always a pleasure to be here.
Yeah,
Thank you.
thank you very much. As we always say, early intervention leads to better outcome, and early intervention can only be achieved by early diagnosis. So thank you for listening into the series today. I know some of the things we've talked about today would probably have generated some questions or need to seek clarification. So I'm happy to take questions, and I'll invite you to send your questions to eim@drtakon.com. Thank you for listening in.